Hello everyone. Today I will be doing my cardiopulmonary patient presentation. My patient was diagnosed with 2 cardiopulmonary diseases, COPD and asthma. But first we're going to learn a little about COPD. COPD, or chronic obstructive pulmonary disease, is a long-term lung disease that refers to both chronic bronchitis and emphysema. COPD symptoms include persistent cough with mucus and shortness of breath. There are 4 stages of COPD: early, moderate, severe, and very severe. Treatment includes medication and lifestyle changes. I also have a video for you guys to watch, will be in the next clip.
These men and women are fighting a common enemy, COPD, chronic obstructive pulmonary disease. Their lungs don't work normally. Every breath taken can be a struggle. What do they believe to be the cause?
Too many cigarettes. Smoked too long, about 40 years.
I started smoking when I was about 17.
My wife says it's from 40 years of smoking.
That's true for about 85% of COPD cases.
We do see occasional patients that have various industrial exposures that can seem to contribute to that, but often they smoke cigarettes too, and so it's probably a combination of factors.
Consider what happened to 59-year-old Gregory Wright. As a firefighter, he was exposed to burning plastics, asbestos, and chemicals. Then he worked at an airport breathing in noxious fumes and gases.
Did you ever smoke? Yes, I did smoke for 30 years.
Another troublesome combination?
Asthma seems to be a predisposition that if you are an asthmatic as a child and then smoke cigarettes, then you have a fairly significantly higher risk of developing COPD later in life.
Then there's a particularly lethal mix, a genetic or hereditary predisposition due to alpha-1 antitrypsin deficiency.
I was diagnosed with alpha-1 in '99, but I'd had symptoms for years. And being a flight attendant, I had a hard time keeping up with the rest of the crews.
Although rare, people like Diane Kay have low levels of a so-called lung protector protein that's produced by the liver.
It took me forever to walk up from the driveway to get the mail. I'd have to take breaks, and you just think you're getting older, and at that time I was a smoker, so you think, you're older and you're smoking, what do you expect?
She was susceptible to colds, bronchitis, and laryngitis, and it took her forever to get over these illnesses. The early COPD symptoms are often missed.
Even people in their 30s and 40s will have the so-called smoker's cough. They think that's normal. They think everybody gets up in the morning and coughs up some stuff. That's not normal. That's the beginning symptoms.
Shortness of breath tends to develop in the late 40s and 50s. Diane finally had to give up her job.
They kind of frown on flight attendants walking on an airplane with an oxygen mask.
Eventually, it became so difficult for Diane to breathe that she ended up needing a lung transplant. Her advice? Don't smoke.
It basically caused me to have a transplant. If I hadn't been a smoker or worked in an environment with secondhand smoke, I probably wouldn't have had to have a transplant. I never would have gotten as sick as I got as quickly as I did.
For WebMD, I'm Rhonda Rowland.
My patient was also diagnosed with asthma. Asthma is a condition in which your airways narrow and swell and produce extra mucus. This can make breathing very difficult and trigger coughing, wheezing, and shortness of breath. A fun fact is that asthma cannot be cured, however, the symptoms can be controlled. It's also a short video from the American Lung Association to further explain asthma.
What is asthma? This animation is brought to you by the American Lung Association. People with asthma have hypersensitive airways. Their lungs react to things that may not bother other people. Asthma can cause significant changes within the airway, all of which narrow the opening, making it difficult to breathe. This is how the airway looks in an airway without asthma. The airway is pink and clear, with no interior swelling, and the muscle bands around the airways are not tight. There is no mucus overproduction. Air moves freely through the open airway. Untreated or poorly controlled asthma can cause changes in the airway that may be irreversible. When you have asthma, 3 main changes can occur in your lungs. The first is inflammation. This makes airway tissue irritated, red, and swollen. When you have asthma, inflammation is always there, even when you are not experiencing symptoms. When the tissue becomes inflamed, the airway narrows and airflow is decreased. The second change is bronchoconstriction. This is the tightening of muscles that surround your airways, further reducing the opening. The third and final change that occurs is an increase in the secretion of mucus, which further blocks the airway. When someone with asthma comes in contact with an asthma trigger, such as pollen or tobacco smoke, one or all 3 of the processes, inflammation, constriction, increased mucus production, can occur, all of which contribute to the narrowing of the airway. This is known as an asthma attack or episode. Thank you for viewing this animation from the American Lung Association.
Okay, COPD and asthma have both similarities and differences. The similarities are wheezing, chest tightness, shortness of breath, mucus production, and also coughing. They both can be triggered environmental or individually. The differences between asthma and COPD is that asthma is usually less than 40 years of age, and COPD is often 40 years and older. Smoking is usually caused with COPD. Allergies is usually for asthma. The spirometry for asthma is pretty much normal. For COPD, it is not normal at all. Now on to my patient. The history of present illness. I have a Caucasian female with a past medical history of COPD and severe arterial sclerosis. She presented to Forest City Medical Center in Arkansas on 3/2/20 with a complaint of shortness of breath and wheezing that has been occurring for the previous 2 days. Also, a cough which started yesterday. On arrival, the patient was placed on BiPAP due to her increased respiratory rate. Troponin level was 2.34. Cardio was consulted, and cardio recommended a heparin drip. While in the emergency department, the patient was given Levaquin 750 mg, normal saline 1 liter, Ativan 1 mg, and the patient was then intubated. The patient was awake on a ventilator, stable and no acute distress, and the patient was transported to St. Francis Hospital per family in Memphis, Tennessee. Her past medical history, asthma, COPD, she's on home prednisone, hypertension, hyperlipidemia, and she's also tobacco dependent. Her past surgical history, she had her appendix removed, she had a hysterectomy, and she also had her tonsils removed. She's also had a cardiac cath with PCI stent ×6. Subjective, she's complaining of a productive cough, and patient states that it's hard for her to breathe. Objective, her vitals, general, lying in bed, intubated, no distress. Respiratory, very mild wheezes. Cardio, she has a regular rate and rhythm. And her labs, her white blood counts was 2.2. Her glucose was 220. Her lactate was 3.5. Her ABGs from Forest City Medical Center, her pH was 7.25. CO2 was 53. Her PaO2 was 51, and her bicarb was 22, which is metabolic acidosis. I also have a chest x-ray, if you guys can see that. That is a X-ray of my patient. I'll let it focus. Okay. For the assessment, she had acute hypercapnic and hypoxic respiratory failure, COPD with exacerbations. She has a STEMI, diastolic dysfunction, asthma, essential hypertension, hyperlipidemia, and she's also tobacco dependent. The plan for my patient was to continue minute ventilation, wean O2 as tolerated, change her vent settings to AC 16, 465, and 40%. A DVT GI prophylaxis. She's getting Atrovent and albuterol Q6. We want to stabilize her hemoglobin and hematocrit and replace her electrolytes as needed. And we're going to follow her closely. In conclusion, the day that I found this patient, I went in and did a regular vent check and assessed my patient. And she was wide awake, trying to tell us that she wanted the tube out, and she was breathing well over the vent. Everything looked pretty normal. She was we extubated her on the 6th of March to BiPAP, which was nightly. And this concludes my patient presentation.